Good afternoon, everyone. I'm Heather Ciccarelli. I'm the Director of the Patient Navigation Initiative here at the American Cancer Society. I'm delighted to welcome you to session 2 of our first webinar series. The overarching theme is advancing equity through patient navigation. We kicked the series off on June 5th with our keynote speaker, Dr. Rob Wynn. We have terrific speakers for you here this afternoon. And on behalf of the American Cancer Society, I am proud to welcome you today. This webinar is being recorded, and the webinar recording will be sent out later this week by email. During the session today, we'll not be able to open the mics for you to ask your questions. But we do ask instead that you post any questions you may have in the question mailbox in the Zoom panel at the bottom of your screen. The panelists will answer as many questions as they're able to during the Q&A period today. We may not get to everyone's questions, but we do plan to send out a document at the end of the series with answers to any unaddressed questions. I'd like to take a moment to give special thanks to our sponsors who support our work. Sponsorship for this initiative was led by AstraZeneca and the Janssen Pharmaceutical Companies of Johnson & Johnson, along with Bristol Myers Squibb. Additional funders include GlaxoSmithKline, Daiichi Sankyo, Novocure, Pfizer, Santa Fe, and other funders. Thank you so much for your support. The series is co-moderated by the National Navigation Roundtable co-chairs. Today, our moderator is Miss Andrea Dwyer. She is the director and founding member of the Colorado Cancer Screening Program at the University of Colorado Cancer Center, which is largely focused on colorectal cancer. The CCSP, or the Colorado Cancer Screening Program, is now growing the prevention and cancer control work to hereditary and lung cancer screening initiatives and serves as the co-investigator on a number of cancer prevention and cancer control research grants. At the state level, Ms. Dwyer is on the executive committee of the Colorado Community Health Worker and Patient Navigation Collaborative to help advance this work in Colorado, and she's also the chair of the Colorado Cancer Coalition. Andy is the co-chair of the National Patient Navigation Roundtable, which is supported by the American Cancer Society. She also advises Fight Colorectal, a national colorectal survivorship nonprofit, in their health promotion and research aims for the growing number of colorectal cancer survivors and advocates to reach the public health, research, and medical community for better programs. Clinical trial access is an important part of the work of Fight CRC and her role as an investigator for the American Cancer Society Patient Navigation Capacity Building Grant at the University of Colorado. And it is my pleasure to welcome Andy today, and I'm gonna turn this over to her so that she can welcome our first speaker and say hello.
Hi, everybody. So thank you so much, Heather and team, for having me. And on behalf of the National Navigation Roundtable, we are super excited for all of the great work. So I think that after building off the first session, we're really going to concentrate today on how navigation can impact the structural clinical barriers to clinical trials participation, with specifically an emphasis on the infrastructure, workflow, and metrics. And I'm super excited because two of the panelists, as Heather mentioned today, are the foremost experts in this work. And I'm excited to join in because I know even our work in Colorado, we're really thinking super deliberately about the work we're doing. And I think both of Mary and our team members today have a lot of expertise to share. So I'm super excited about it. So we're gonna go ahead and jump in. And I have the opportunity to introduce Dr. Mary Salazar, who is Director of the Oncology Patient Experience at UT Health San Antonio Mays Cancer Center. The Oncology Nurse Navigation Program, which she directs, falls under the Department of Patient Experience, which I love that we're definitely choosing words that are more patient-centric and really talking about the patient experience. Dr. Salazar is a GI oncology nurse practitioner with more than 10 years of experience in surgical oncology. and greater than 8 years of experience in medical oncology. She received her doctorate of nursing practice from UT Austin in 2020. And she has a unique experience in care coordination of oncology navigation due to the many roles she's held in the space over the last decade. So Mary, I'm going to turn it over to you to kick us off today to talk about your experience, and just super excited to have everyone joining us today. I know that we're over 210 that are actually on live, with actually even more registered. So huge kudos to ACS and all the great work for this capacity grant. So Mary, I'm going to kick it off to you and have you take us into today. Thank you.
Thank you. Thank you for inviting me to speak today. The slide in front of you here lists my objectives. The first objective has to do with building a scaffolding for an oncology nurse navigation program that prioritizes health equity. Here at my organization, we have oncology nurse navigators, but we have a whole navigation team. And you'll see that on the subsequent slides. The second objective has to do with building the structure of the navigation program, so to socialize clinical trial-based care to our patients. And then the third objective is how the supportive roles of the navigation team complement one another to increase value-based care and health equity in clinical trials. So here you'll see a lot of roles, and we don't have all of these roles at our organization, but we do have quite a few. And this is just to show the point that oncology care is a team-based sport. And with any sport, all the team players are going to want to know their role, so they're not tripping over each other on the field, and so that they can get the best goals, the best outcomes from their participation. So on the left-hand side, I've kind of divvied it up to the navigation supportive team. And on the right-hand side, I've divvied it up to the care team. There we go. And you want to make sure that each team member has a clear position description with job duties so that they are easily understood by themselves and everyone else on the team. Oh, sorry, I went one slide ahead. So this is our position descriptions. And I know this is a lot of words to put on one slide, but it's just to make a point that you really want to have clear position descriptions between your oncology nurse navigator job duties and your primary clinic nurse. That's what the PCN stands for, primary clinic nurse job duties. And then I've also listed up there the clinical trials coordinator, because at times that can be a nurse as well. So the oncology nurse navigator is really helping the patient to mitigate barriers and bringing in resources from the organization itself as well as the community to get the patient timely care, while the primary clinic nurse is really embedded in one particular clinic, not crossing disciplines, and really expert in physical exams. They might be administering medications such as injections and doing a lot of disease-specific education for the patient. And then, as you know, the clinical trials nurse is really screening patients for trials, looking at inclusion-exclusion criteria. Trying to go forward. Sorry. Oh, no. Sorry. Here we are. So here we have building the human resources, having your supportive navigation team, which is disease site based, but not discipline specific. The navigation team crosses the disciplines, where the care team or the primary clinic nurse is disease site based and discipline specific. The medical oncology nurse stays the medical oncology nurse. She doesn't cross over to Surg-Onc and Med-Onc, where the navigation oncology nurse navigator will cross the disciplines between medical oncology, surgical oncology, and radiation oncology. So the navigation team, whether it's a social worker, dietitian, they will go to where the patient is, and the care team has the patient come to them. When you're building the structure of your navigation program, you want to make sure that the navigators are attending specific meetings, and I've kind of laid out the rationale. The most important meeting for our navigators is tumor board. All the new new patient cases are presented at the tumor board, and it's here where the navigator begins to learn what the treatment plan is going to be for the patient. But they also learn from perhaps residents that have been in the hospital, because we are an outpatient center. They will hear that there are patients that are about to be discharged that are unfunded or underfunded. And it's at that point where the navigator can step in and say, well, this patient's going to need an EKG, or they may need pulmonary function test, or they may need a feeding tube or a port. And she can try to get those things placed and taken care of before the patient gets discharged. And then she or he can get the patient on active treatment sooner by getting those things taken care of when the patient's inpatient. That's just one example of the benefit of having the navigator attend the tumor boards. Having trouble advancing these, sorry. Then we have clinical disease site meetings. These are our research meetings, and this helps the navigators to have an awareness of what's happening in our clinical trial space that's specific to our organization, what trials are in the pipeline, what's about to open, what's about to close, what slots are available, the inclusion and exclusion criteria. And not because she's going to specifically screen any patient, but just so that the navigator has an awareness of what's happening in our organization. And then our program development meeting, where they may learn about new standard of care, innovative treatments that are coming down the pipeline that may be available at our own center. Now, when we have the navigators meet every new patient, and they do an assessment tool, which is the NCCN thermometer tool. It's the distress thermometer tool, and the patient will rate their distress on a 1 to 10. And it's not that the navigators are accountable to decrease the distress level, but we do want them to bring tools and resources to the patient to help the patient mitigate their distress levels. So on the right-hand side of this tool are the problems list. If there's physical concerns, the navigator would bring that to the physician who's taking care of the patient. And then the psychosocial concerns would go to the other players on the navigation team, such as we have a psychologist or social workers and others. And this is built into our electronic medical record, this NCCN distress thermometer tool with the barriers. So after they've gone over this assessment tool with the patient, they will ask the patient, have you ever considered clinical trial-based care? We want them to ask every new patient every time. And some patients may say, yes, I have considered it, and I would want clinical trial-based care if that is what I can get. And you would let the physician know that that's seeing the patient that day. And then this question is kind of a conversation starter, where that if a patient says something like, yes, but I don't want to be a guinea pig, or yes, but clinical trial care is more expensive. And then the navigator can help to debunk the myth and get the patient in contact with any resource that might be able to support whatever concern the patient had. And that's where the second yes, but comes in, and that they may have real concerns about barriers with clinical trial-based care, such as travel and housing. And if they say absolute no, which I have had a patient say this to me emphatically, then you want to dig a little bit deeper, not to coerce the patient in any way, but just to make sure they're making an informed decision. My patient that said absolute no just never wanted to get an extra needle stick for any reason. So we just were able to talk about that a little bit and make sure that the patient's making an informed decision, that the navigator's not coercing the patient in any way. And then here's my pop-up just to say that the navigator wants to be familiar with any community resources so that they are able to bring them to the patient. This is our conceptual model of our navigation program. The new patient referral coordinator will get the referral, and if there's any questions regarding which clinical disease site the patient is to go to, they may reach out to the navigator. It may be very standard, and they just schedule that first appointment. During the first appointment, the navigator will see the patient either before or after the physician sees the patient. They will do that NCCN distress thermometer assessment, and they will be in the middle, the patient-centered care, and work as an advocate to get those referrals and consults sent out quickly so that the patient can get all the resource and support they need to get to treatment, which would be standard of care and/or clinical trial-based care. we have an electronic medical record, and within that, we built metrics that the nurse navigator documents. And the first metrics is from the referral shell to the first appointment. They'll document how many days in the electronic medical record. So at the end of the month, we can get a report. They will also document date from first appointment to date of first modality. So first appointment might be with med-onc, surg-onc, rad-onc, and first modality would be infusion chair, radiation vault, or operative theater. And then they would document any no-shows and the reason why for the no-shows, the variable. And that's on the right-hand side of the slide. We have the variables broken up into categories: patient, system, and provider. They document the distress level in the EHR and the number of barriers and the types of barriers, and that's on drop-downs and radio buttons. And then, as you guys know, a patient barrier may be that the patient is waiting for the birth of a grandchild or perhaps a wedding next week, and they don't want to come next week, but maybe they want to come in 3 weeks. There are different barriers, and we want to just document them so we understand what's going on with our patients and our systems. Oh, sorry. Trying to go backwards. Okay. So on the electronic medical record, we have a documentation toolkit with discrete fields. We also have a care coordination flow sheet, and the customers of this flow sheet are really the other participants in the navigation team and the providers. So the providers can know if a social worker is already working with the patient, if the financial counselor is already working with the patient, and what date did the financial counselor last talk with the patient. And I will show you that in just a few minutes. Also, our Epic analysts and our team developed a white paper and a quick help guide so that as we onboard new navigators, it's easily to get them up and started. We define what the notes are that the navigators are documenting. So we have the new navigation note, the discharge navigation note, and the PRN note. Our navigation is up front from the time the patient comes in as a new patient until they start on their first modality. We have the telephone note. The message encounters is to communicate within the electronic medical record among the team, the care team and the support team. And then we have real-time Epic or EHR chats that we use. And then I also added here that it's a good idea to have your navigator on your patient education committee, because then everyone's teaching from the same tools. And I think that makes it less confusing for the patient if everybody's using the same tools. And then we also have a discrete field in our oncology nurse navigation notes that say the style of learning. Does the patient want to learn one-on-one verbal, or are they more comfortable by taking something home that they can read later? Or are they more comfortable with video education? There we go. This is the care coordination sheet that I spoke of. And you can see it has the nurse navigator, the start date, the end date, the social work, dietitian, food pantry, and all of the supportive resources, and it's built into our electronic medical record. Then for return on investment and sustainability, the navigation program is a cost item on your budget. However, we are an ACO, which is an accountable care organization, and we do participate in the CAHPS and the MIPS survey, which generates a larger set of patient experience measures. So I put kind of a definition to some of those acronyms. And the 3 core measures for the summary survey measures is getting timely care and appointments and information, which is right within the navigation space, and then the care coordination. So the MIPS is the merit-based incentive programs. And if we can score well on our Press Ganey surveys, then hopefully we would be able to then get some merit-based incentives. And that's our return on investment. And here's a URL where you could learn more about that if you choose. And then to just go over a little bit more about our ACO, the navigators expedite care by mitigating the barriers, and hopefully they can get patients to care in a more timely manner, thus perhaps treating a lower stage disease. And we all know it's less expensive to be able to treat a lower stage disease. The Navigator also helps to standardize processes, thereby creating a high reliability environment and thus a higher quality care environment. The hope is that with the Navigator and the clinical trials coordinator working together to get patients on and keep patients on treatment plans and clinical trials, that we would definitely have better clinical outcomes. And our second opinions may be more likely to stay at our organization if they know that they have a nurse navigator that can help guide them through the appointments and all the complex procedures. So these are the things that we use to justify our return on investments. And then most recently, we haven't started this yet, but we hope to in the next 16 months. Principal management codes came out in January, and they are incident to billing, time-based billing, and we will have the navigators begin the principal management code incident to billing within the next 6 months. I don't know that this will cover a whole FTE for a navigator, but I think it will help support the program. So for takeaways, the first objective was to describe how to build the scaffolding of a navigation program that supports health equity. And we talked about asking the patient every patient, if they're interested in clinical trial-based care, so that everyone has an opportunity to open up that conversation. The next objective had to do with enabling, having the oncology nurse navigation program enable socialization of clinical trial-based care. And with this, we have the navigator and the clinical trial nurse coordinator, clinical trial coordinator, start to work together to not just get the patient on the clinical trial, but to keep them on track. As other barriers come up with clinical trial-based care, the two of them can work together and complement each other to try to keep the patient on that plan. And then the third objective is understanding how these supportive roles on the navigation team complement each other as well. And just to understand that it takes a team, that a navigator can't be put alone on an island. It's more beneficial to have them immersed in the team, and that they are not to take over the tasks associated with another role. They're to stay right there as the patient advocate, making sure that the resources are getting to the patient so that the patient can have the best clinical outcomes possible. And that's it. I'll take any questions.
Oh, Mary, that was fantastic. So asking for a friend, do you have just, you know, you were talking about all of the constructs with the scaffolding and really that flow, which I thought was great. Do you have materials or any ancillary materials or education pieces that have been utilized in practice that you would be willing to share with the group that have helped really augment these conversations? Is that something you can share?
Well, we don't have any specific handouts that we give to the patients. Mm-hmm. We have that distress thermometer mm-hmm. with the questions, and that's really what gets a lot of the conversations starting, and then just remembering to ask every patient every time if they're interested in clinical trials. But we don't hand out anything specific to the patient in that regard.
Right. So it's a driven through a conversation led, but you actually hand out. Okay. Awesome. I was just very curious in implementation, but of course, open-ended questions with some good tools, the name of the game. Megan had an excellent question, which I think comes up for many of us when we're thinking about the clinical trials. And Megan specifically asked, have you ever considered clinical trial, when you ask the question, have you ever considered clinical trial-based care? If you don't know if they're eligible for a trial, do you ask that regardless knowing eligibility? Is that correct?
Yes, because they may not be, well, yes, because it's not the nurse navigator's job to screen for a clinical trial. So mm-hmm. It's not, you know, her role to say, I think this trial is best for you, mm-hmm. but to kind of gauge the patient's knowledge with respect to clinical trials and to debunk any myths the patient might have, and to let the patient know they may be eligible, and it's something to discuss with their physician or care team.
Okay, because I think the question was, you know, specifically if there wasn't a trial that was open within your specific medical facility or site, how to deal with that. But what I hear you saying is it's that navigator's job to help open up that conversation, create that conversation, then to make those connections to the provider about specifics enrolling. So the provider or maybe a clinical trial coordinator around those specifics and those handoffs. Just out of curiosity, do you know what the process is if you have patients right now who aren't eligible for something that's maybe open within your facility? Are there opportunities for referral out, or how does that happen for your facility? Do you know?
Well, I think because we're an academic facility and we do partner, we have an affiliation with MD Anderson Houston as well. So we have patients that go in between our facility and because we're 3 hours away in their facility for clinical trial-based care. But our physicians will discuss that with the patient if they feel that there is a trial that they may be a candidate for that might be in a completely different state.
Mm-hmm.
They would just talk to the patient and see what the likelihood is of the patient's interest in that.
Okay, great. So let me just make sure, Heather, we have time for a few more questions. Is that right?
I think that we will move on to our next speaker and then have lots of questions, hopefully lots of questions at the end that we can address to both panelists.
Okay, that sounds,
please. Thank you.
That sounds great. I always lose track of my time zones being here on the West Coast, so I wanted to make sure. So Mary, excellent presentation. And I'm very excited to also then bring in our second panelist for today, Dr. Shanita Hughes-Halbert, who is the Vice Chair for Research and a professor at the Department of Population and Public Health Sciences as the Associate Director for Cancer Health Equity at the Norris Comprehensive Cancer Center, and Dr. Arthur Priscilla Uline Chair in Women's Cancer, the Keck School of Medicine, University of Southern California. So that is a good title there. But the goal of Dr. Hughes-Halbert's research program is to improve the precision of multi-level strategies for achieving health equity by identifying diverse determinants of minority health and cancer health disparities, and by translating this information into sustainable interventions in clinical and community-based settings to improve cancer outcomes, chronic disease management, and disparities population in local and regional geographic areas. Dr. Hughes-Halbert is a nationally recognized expert in cancer prevention and control amongst diverse populations, and research is supported by numerous grants from the NCI, the National Institute of Minority Health and Health Disparities, and the Veterans Affairs Medicine Center. Previously, she was a member of the Board of Scientific Advisory to the National Cancer Institute and the National Human Genome Research Institute Advisory Council. Dr. Hughes-Halbert is a past recipient of the AACR Distinguished Lecturer in Cancer Health Disparities Award and is a member of the National Academy of Medicine. So I'm going to go ahead and pass it over to Shanita to continue our discussion today. So excited to have you on.
Yeah, good. Good morning, good afternoon. Hello, everyone. Thank you so much for the opportunity to spend some time with you talking about this important topic. I really want to thank Dr. Salazar for her great presentation and for really setting the stage for what I wanted to share with you today, which is around sort of the issue of innovative strategies for addressing enrollment and barriers and enhancing participation among diverse populations. So I'm really excited to be here and just want to thank all of the organizers for this opportunity. I wanted to start with just why I think the topic of clinical trials participation and navigation and all of the tools and resources that we can use to enhance access to clinical trials is really important, because it plays a key role in what I think is our overall vision for cancer health equity, which is to ensure that populations have access to the right medical care at the right time and in the right way, so that we ultimately, in this context, I think, have the most effective strategies for treatment. Clinical trials, as you've already heard, I think plays a really important role and equity among diverse populations. And one of the things that has been a real significant focus of for many years is how to enhance the participation of disparity populations in clinical trials. I'm highlighting one slide in particular, work that is being done through the NCI Community Oncology Research Program, which has been, I think, really important for expanding our thought process and processes for how clinical trials are conducted. And so what I think has been really important about this program is that in addition to having clinical trials being conducted at academic medical centers, at an NCI designated cancer centers, the Community Oncology Research Program really broadened access in an important way by making clinical trials available in community settings where patients, particularly those from diverse communities, are likely to receive care. So the whole idea behind NCORE is that it overcomes sort of the transportation issues and other challenges that patients may face with being able to access and have the opportunity to participate in clinical trials. Even with that, we know that there's still important opportunities to improve access, and that this is still being held at the forefront of our attention through recent guidance that I wanted to make you aware of that is being issued and developed by the FDA, where they are making plans to have a more focused effort on diversity plans that really, I think, hold investigative teams more accountable for improving the enrollment of diverse participants in clinical trials. I think this is really important because I think it sort of keeps us, it holds us have greater accountability for ensuring that there's actually specific concrete plans for how patients from diverse groups will be given the opportunity to participate. And certainly creating the infrastructure that was just described in the previous presentation plays an important role in that process. I think this is really important because we know that there are several barriers to clinical trial participation. These include access that are at the patient level and at the clinic level. And sort of, as you can see here in this recent presentation, which I think is a really nice depiction of all of the ways in which sort of the access, awareness, the institutional climate in which the cancer care and the clinical trial is being conducted, as well as the workforce diversity. And so we've already heard, I think, a really great example of the different types of positions and workforce that's needed to really support clinical trials participation in the most robust and equitable way. But I wanted to just sort of spend some of my time today talking about the ways in which I think we still see some inefficiencies in clinical trial recruitment. And as you all know, just highlighting the component that recruitment and retention is a very complex process. And it really starts within the context of clinical trials from where and how patients are screened in the cases where they may not be screened for participation. They may not be invited to participate in a clinical trial or may decline participation. And then finally, I think we also have to think about retention and that patients may not complete all of the study procedures. And I think one of the things that's been really important for my thought process in this space is that we have to be thinking about participation in cancer research and clinical trial, and certainly for clinical trials, as a healthcare decision. And so for that reason, I think we've had to my view, we have to really think about participation in clinical trials from the perspective of what makes it easy or difficult for patients to participate in clinical trials, and then to develop strategies that are evidence-based that address those barriers and facilitators. And importantly, I think we have to have tools and resources available to be able to monitor each phase of the recruitment process, starting with screening, enrollment, and retention, and then ultimately so that we're in a position to evaluate participation outcomes. I think these are sort of the main components of really understanding where and how patients may opt in or opt out of participation in a clinical trial. I wanted to share with you some of the work that my team has been doing to understand, in this case, African-American participation in a wide variety of different types of studies. And just to share with you that when we think about this from the perspective of patients making a decision, that will involve sort of weighing the pros and cons, weighing the barriers and facilitators, that it's really important just to have a good understanding of how all of these factors might influence one's decisions to participate or not participate. One of the things that I think has been really interesting from my perspective is that when we ask individuals how likely it is that they might participate, in this case, what I'm showing you now is participating in a hypothetical cancer genetics research that had the attributes of being sponsored by the government, the federal government. It would involve answering questions. The data may or may not be used for current and future studies, and that they would not receive results, is that we have a really, I think, a relatively low level of interest and participation. And so I think this is also sort of comes into mind that there's been numerous studies which have examined barriers and facilitators to participation in clinical trials. And this work I think is really important for us to keep ahead in understanding how individuals and patients may be making decisions and some of the factors that they may be thinking about as their approach for participating in clinical research. What I wanted to share with you next is an example of work that my team has been doing within the context of precision medicine and minority men's health. What was interesting about this and relevant for this particular consortium is that it brought together multiple institutions to really think about how to address and develop strategies to enable precision medicine within the context of addressing health issues, and in this case, particularly prostate cancer initiation, progression, and survival among African American and white men as part of a multi-regional consortium. As part of this consortium, we conducted translational research to understand the ways in which multi-level drivers played a role across the entire continuum of prostate cancer diagnosis, treatment, and recovery. And as part of these studies, men were invited to participate in a prostate cancer vaccine trial. They were had an opportunity to participate in an observational study that was designed to understand multi-level drivers of prostate cancer outcomes among men who had been treated with the radical prostatectomy, and then a final study that was designed to understand the effects of vitamin D supplementation, first as part of a randomized trial, and then second as part of a prospective observational study in which men received vitamin D supplementation. One of the things that I think I wanted to share this example with you is because it really enabled us to apply some of the novel tools and strategies and really leverage the resources that were available to support our research to enhance recruitment and retention across all of the projects that I've just described. One of the things that we were really focused on was understanding how social factors, clinical factors influenced men's participation across all of the different studies. And to do this, we also created our own infrastructure that had the basis of understanding men's sort of social context where they're receiving their clinical care. And we also were supported by a data integration core that was designed to develop tools and resources to identify and extract data on social determinants from the clinical notes and the electronic health record, really for the purpose of leveraging the investments that had been made to implement an electronic health record system at the institution. One of the things that I think is really important to think about when we think about sort of the electronic health record is that it really is a tool that can facilitate the clinical trials sort of functions, critical functions within the context of clinical trials. For instance, there's some examples of where the electronic health records and particularly artificial intelligence and machine learning approaches are being used to pre-screen patients for eligibility to participate in clinical trials, as well as other types of cancer research. So this is a really important tool that I think can be leveraged further to enhance access among diverse groups. And what I wanted to share with you next is that, we actually use this approach to support our research. And so in one of our projects within the Precision Medicine Center, we identified patients who had participated, had received care at an NCI designated cancer center and had donated a tissue sample as part of having a radical prostatectomy. So again, you can see where the clinical infrastructure was really important and valuable for enabling us to activate our enrollment procedures and recruitment processes within the context of an academic medical center. As you can see here, our primary outcome for this analysis was enrollment in a social determinant survey and activation of the patient portal. And I do think it's important to draw your attention to why we focus on these two particular outcomes. One is that we were interested in enrollment rates to be able to understand the ways in which men were or were not able or willing to participate in a study that had a relatively low burden of a low participation burden, and that they had to complete that the main requirement for participation was completing a phone survey or returning a completed social determinant survey in the mail or online. And then secondly, we were interested in patient portal activation because one, it has become a primary tool for enhancing patient-physician communication. It's also becoming an important tool for delivering supportive services to patients. And lastly, it's also an important tool for delivering cancer control interventions. So what you can see here is that using this institutional resource, the electronic health record, to launch our recruitment procedures, which involved identifying men, identifying patients rather, sending them an invitation letter, inviting them to participate in this social determinant survey. 31% enrolled, and then of those, 66% had activated their patient portal. What really was interesting to us is that there were I think, as expected, racial differences in patient portal activation and enrollment in the study. But what was really intriguing for us is that we were very interested in the overall social context in which men were living, whether they lived in an area that had higher versus lower levels of social deprivation, and then the association between sort of the social context of one's general life circumstances and how that influenced our participation outcomes. And what I'm showing you here is that there were, that social deprivation was associated with a significantly reduced likelihood of both enrolling in the study and activating their patient portal. So I think this is relevant for clinical trials participation, because what it says to us is that even for the broader context in which men are living, which patients are living, it plays a role in their ability to participate in clinical trials, and that sort of the understanding the social context is critically important in a role for navigators. The second thing I want to draw your attention to is that in this same sort of context of our Precision Medicine Center, this was a study, what I'm showing you here, and I'll draw your attention to the sort of the first row where we see that this was a project that was our project that was activated and conducted in the VA system in the southeastern part of the United States. And what this shows us is that, you know, there was about 55%, and these were men who were undergoing a prostate biopsy. And so we see lower levels of participation. Our sample was about 60% overall. But within the distribution, and I think this is important to think about from the context of sort of the broader sort of disease burden, that 55% of our sample were African American and 45% were white men who were undergoing a prostate biopsy. So this is important for us to understand from the perspective of sort of equitable access, and where and how you conduct the study is really important. This was a project that was integrated as part of the clinical workflow. This was also conducted in a study that had high representation of African American patients. So what this says to us is that the context is real, the clinical context, and having the study integrated, be highly integrated within the clinical workflow is critically important to ensuring equitable access, and access that is representative and perhaps more consistent with the burden of disease. And lastly, wanted to share with you two examples, an example from other research that was again conducted within an academic medical center, but this time within the context of breast cancer. And for this research, we were really interested in understanding the ways in which stress responses are manifested among African American breast cancer survivors. And for this research, we integrated a randomized trial in which breast cancer survivors were randomly assigned to receive to complete a temporal discounting task, either immediately after or shortly or longer term after completing a stress exposure test. And this was important to us because it really was helping us to understand the ways in which sort of stress responses, temporal discounting, all were associated with treatment compliance and adherence. So again, within the context of this behavior change study, we embedded a clinical trial to help us understand some of these basic behavioral processes and how they were associated or influenced by immediate stress responses. And again, these patients were recruited using the electronic health record or in person during the oncology care visit at an NCI designated cancer center. And what I'll share with you is that these were, again, patients who were diagnosed with early stage or locally advanced disease, and that they were invited to complete multiple procedures as part of their participation. And so those procedures included a baseline telephone interview that was done over the phone. They had to come and complete 2 laboratory visits. There was a medical record abstraction and then a 1-month follow-up telephone interview. And again, our final outcomes were stress reactivity and treatment compliance. Our final goal in terms of study enrollment was 120 women. I should point out that the study was conducted as part of was conducted during COVID. And so we did experience a significant restriction in terms of our ability to complete enrollment procedures because of the impact that COVID-19 had on all research activities. But what I want to share with you is that as a result of having access to an electronic health record system that enabled us to identify women pretty effectively, and then also being able to be on site in the clinic, working collaboratively with the clinical staff, we were able to come close to meeting our recruitment goals and then have a fairly robust participation in all of the subsequent procedures. And we were really pleased with that even during the COVID-19 pandemic, we were able to really have a successful recruitment experience. But what does this mean? I mean, so one of the things that we've learned is that there are a couple of sort of critical points. One, we have to sort of work within the broader community context where patients are receiving their care. We have to leverage the institutional resources that are available to us to enhance the identification and referral of patients. And what we're doing, addressing those issues as part of new research that's being funded by a pharmaceutical company to help us develop and sort of address all of these issues simultaneously as part of a broader effort to connect patients to cancer clinical trials. And as part of this, we're developing a community oncology referral network in Southern California to enhance the referral of patients from disparity populations to clinical trials. So we're implementing some of the best practices and lessons learned from the NCI Community Oncology Resource, and then sort of applying some of the new technologies and tools to better engage with patients. And then finally, we're working through this funding from the Stand Up to Cancer to eliminate enrollment barriers by using an enhanced referral process within a safety net hospital system to sort of work provider to provider to facilitate enrollment among eligible patients to the early phase therapeutic trials that are being conducted at our Comprehensive Cancer Center at Norris. So a couple of lessons learned. One is that health information technology and machine learning strategies are important, but really it involves a team effort to enhance recruitment and retention of cancer clinical trials. As part of that sort of team process, that we really do have to think about messages that are tailored to diverse populations, as well as using multiple strategies to enhance recruitment. So I'd just like to close my comments by saying that, you know, as we all know, recruitment and retention are perhaps the most important, but actually the rate limiting step in studies that involve people. That we can sort of leverage the resources and tools that are being developed within the technology space to enhance, I think, all of the steps in the recruitment process. But even with that, we need to have tailored messages and content to improve the precision of how we reach out to diverse populations. And then finally, I think we have to really understand and develop and have an empirical basis for our future efforts. And so with that, I'm happy to take questions. Thank you very much.
Well, awesome. And my camera is not loving me right now, so it's not turning on, but Shanice, a question that came up, and I think I'm glad actually, one of my questions for you at the outset was almost like, if you're going to have to take a first step, right? Because sometimes folks get really overwhelmed by clinical trial enrollment in general and making sure that we're having really strong representation and we're reaching our communities. But I think your aim one, right, was identifying who is and isn't being, and then looking at those referral mechanisms. Because I think it's simplistic, right? But sometimes that first step out can be so hard when we're considering that work. I guess anything you want to add to that in terms of like, if folks are just really starting to get enmeshed in the clinical trials work and really looking at equitable approaches and seeing diversity and representation, anything else is a big first step forward?
So I think a really important step is to be really thoughtful about keeping track and developing sort of a very systematic way of understanding the recruitment process from the very beginning. One of the things that I think is really challenging for the broader field is that, you know, we know that only about 5 to 10% of patients enroll on clinical trials overall, and that the participation rates are lower among diverse communities. The reason why we know that is because we're able to enumerate who's identified as who's screened for participation in clinical trials, who's eligible for participation, who's invited to participate, who accepts or declines participation, and who goes on to complete sort of the procedures involved in any type of study. I think those are really important metrics that need to be captured systematically. And I'm not sure that this is always done consistently across institutions. So I think has been a really important focus for my own research. It's been one of the things that I think has been really a key issue among the NCI Community Oncology Research Program, is to really understand who's invited to participate. One of the things that we learned as part of one of the projects within my Precision Medicine Center is that, and these were for men who were being invited, who were, the population were men who had been treated for prostate cancer and who were at high risk for recurrence. And the investigators were conducting a prostate cancer vaccine trial. And so what we found is that most patients just weren't asked to participate, and that really didn't differ between Black or white men patients. And so I think, the being able to understand that and to figure out, well, why is that happening? And then to be able to activate solutions to address, the specific barriers that sort of are in play within that particular context, I think is really important. I see there's a question in the chat about specific clinical trial software, and I'm sorry to say I don't know of any that are ready for prime time use. That's for using to identify patients for clinical trials. We're developing some of the tools locally, but I think it really depends on sort of what the capacity is at each institutional setting.
Great. And then, Shanita, we have one more question, and I think then we'll kick it back to Heather to close us out for today because time is flying. I know there's some additional questions in the chat. We'll make sure each one of our panelists has an opportunity and get back with the group. But I think this is a really interesting question from Jasmine, is how do we address the lack of trust in the medical system by minorities, marginalized communities based on history? Are we developing tools similar to MI to help identify these subtle beliefs so that we can address them to be able to better engage these populations? So I'd really love to hear, Shanita, what your feelings are. And then Mary, if there's anything else that you'd like to share as well as a final comment in terms of tools and thinking about your experience, that would be great.
Yeah, thank you. So I feel like one of the things that has been really informative and impactful from my own perspective is providing information as part of the recruitment process that helps patients to understand why and how participation in a clinical trial or cancer research is important, first of all, and then how it's relevant for their own disease trajectory and for those of for the broader community. One of the things that I think has been really important and consistently found across studies is that individuals, one of the most important reasons for being willing to consider participating in a clinical trial is because it has the potential to not only help them, but also help their communities. And I feel like that's a really important facilitator that can, one is really important. I also think that as Dr. Salazar presented, introducing the concept of clinical trial participation at the earliest point within the treatment process, I think is really important because it helps to demystify clinical trials. And in my view, and I'd love to hear what Dr. Salazar thinks about this, is that it really it doesn't present clinical trials as like the last option, and that it kind of normalizes that it is a treatment option, and it's not something that patients are presented with as the last thing that they can do as their last resort. Dr. Salazar, did you want to add to that?
Oh, thank you. Yeah, I completely agree to introduce the concept early. And to the question about trust, what I say to our patients, you know, this is such an exciting time in innovation in the oncology space. And especially being in Texas, we have Dr. James Allison that won the Nobel Prize for immunotherapy and the PDL. And I just say those folks that went on that clinical trial, you just, there's a reason why they've brought it to human studies. And there's the reason why it's gone from phase 1 to phase 2 to phase 3, whatever trial that patient might be a candidate for. So I try to let them know, like you said, it's not just for those that are last ditch effort, but you know, we're trying to make things more personalized, and it may be that they have a particular marker that this trial is really designed for. And I just try to explain, you know, as much as possible as why they're a candidate, to try to break down, you know, historical trust issues that we've had and explain where we are right now and why it's important right now.
Amazing, everyone. Thank you so much. And Heather, I know that we'll have a number of questions, but Heather, I'll turn it over to you for wrapping us with this 1 minute. But I've really enjoyed this panel today. Thank you guys so much. And I think such valuable contributions. This has been awesome. Heather?
Yes, I would also like to thank Dr. Shanita Hughes-Halbert and Dr. Mary Salazar for your fantastic presentations. I think that what we're learning is that, not what we're learning, what we're seeing evidence of is that this is a very important conversation, that there's lots of interest in it. The questions that are in the chat are so thoughtful, and we will be sure to make sure that they're addressed and that those answers go out to everyone. And this conversation will continue next week. We do have 2 great experts who will be talking specifically about some of their success in increasing enrollment and strategies that they use. So we hope that you will tune in. And again, thank you so very much to our panelists and to all our participants for joining us today, and to our sponsors. And we'll see you next time. Thank you very much.
Thank you.
Thank you.